Well, welcome back. This is number 2 of 5 in our seminar series. And if you weren't here last time, I am Maddox Casey, and this is Say Evans to my left, and we are CPA and healthcare consultants with Warren Averett. We dedicate pretty much our whole career to helping physicians and physician practices with tax, accounting, consulting services. And tonight's series, we're going to cover improving practice profitability, which should be near and dear to your heart concerning some of the current environment that we're in. In our last series, we talked about the current environment, and in our last series, we talked about closing and selling or buying a medical practice. And we talked about the current environment, but I think we should spend just a few minutes revisiting that, rehashing it, and understanding why profitability at this point is critical and necessary to keep a practice running. And so we're going to cover 3 or 4 things here. One, and the most important and the highest, highly talked about topic is the Affordable Care Act. And what is it doing to our practices? The biggest thing that Affordable Care Act is doing to our practices right now is having patients have larger deductibles. Increased deductibles when they have tiered down to from a gold plan to a silver plan, maybe to even a bronze plan. The old days of $30, $40, $50 copays, potentially could be higher copays now, $75, $100 copays, and there may not even be a copay at all. It could be just flat out deductible, which could be as high as $6,300 for an individual or $12,700 for a family before anything's paid. And that's making a large impact on the way we collect monies as a practice.
Yeah, and the increased deductible burden, having to collect that, it may require more time of your staff. You may have to hire additional staff or pay overtime to staff that are already there. So, just beyond the burden of collecting that money, it's adding additional expenses to your practice.
Yeah. In fact, I took a phone call this week. Physician practice here locally asked, look, we're having a hard time collecting money. Is this something you're seeing across the board? Or is this something I should address inside of my practice itself? And my normal answer to that is, well, let's look at your accounts receivable and see if they've grown, and let's see if it's grown on the patient side or the insurance side. If it's grown on the patient side, then we are having a harder time collecting money from the patients. If it's on the insurance side, it may not be something related to Affordable Care Act. It could be that you need to go to work denied claims and other types of, and go see if your claims are being denied, or go work some claims and actually go get the money from the insurance. So it just depends on what side the AR balance is sitting into. The other part that is relevant to increasing practice profitability is the increased burdens on a practice right now. The increased burdens, there's numerous ones, and I'll just name a few. It could be ICD-10 that's looming. Of course, we're quite a ways from there now, or it could be the HIPAA regulations. It could be that we're concerned about RAC audits. What other items are you seeing say that?
Additional expenses to demonstrate, meaningful use, or to
e-prescribe.
Exactly. All the things that you would have to do to prevent your reimbursements from being cut from Blue Cross or Medicare, or just additional things that are going to either take up your time, which is going to reduce your revenues, or it's going to take up your staff time, which could increase your cost.
That's exactly right. And as part of that, as we look around and we talk about your practice and who is actually there to help you earn more money, we know your staff want to work less. We know insurance companies want to pay you less. We know vendors want to sell you more, and patients are getting more and more creative at ways to get outside of your deductibles and to get outside of copays. So everybody's working against you. Fortunately, there are what we consider 2 people working for you. It could be your administrator, and hopefully it's your outside CPA. Those are two people that are helping you increase profitability. We will mention at this point that if you don't have your administrator on a incentive type plan where they're receiving some type of incentive based on profitability of the practice, we encourage that. We encourage that primarily that puts them on your side of the field. They're looking at cost, they're examining revenue. They know that those 2 items, if they can control those and increase profitability, then their bonus is going to get higher. And that way they become on your team and not necessarily don't have a dog in the fight, if you will, for the practice.
Yeah, it's important to make those goals be something they can have a direct impact on and that are measurable and obtainable. They're not unrealistic. If you do that, they'll be motivated and ready to get that accomplished. They'll feel like they're part of the team, like Max said. If they're not realistic or it's hard to really put numbers to it, it could be something kind of ambiguous and it could discourage them from performing their job as well as they were before.
Yeah, so we'll look at some practical steps moving forward in just a minute on implementation steps you can take to increase your profitability. And as a caveat here, we do want to mention we do look at the bottom line. We're accountants, we're numbers. We are trying to push the profitability, but we can push you to a point that you begin to sacrifice your family, your marriage, your health, or even your sanity in order to get to that bottom line number. So we want to mention that don't sacrifice that at all costs because that is worth something to you other than just the bottom line. While we're here, on the slide that is currently up, it has our email addresses. So if you have questions as we go, we'll take questions at the end and address them. But if you have questions on a topic that we're talking about, and for our live participants, we'll let them ask as well, send it to our email and just go ahead. I'm going to give you about 30 seconds right now before we move any farther off this slide to write down my address or Say's address. So we'll stall here for just a moment. All right, you should have had time to write that email address down. It's not that long. Say's is shorter, so maybe you want to shoot him the emails. So we're going to back up here for just a second to get to the beginning. All right, so we're going to cover two items here. First, we're going to talk about cutting cost. What are some practical steps to cutting cost? And then we're going to move into revenue. So we know we have, as a setting, a closing curtain on us. We know that costs are continually increasing, and we know revenue is trying to decrease as people bundle payments, reimbursements get less, and that's what I call the closing curtain effect. What we're here tonight to talk about is how do we open this curtain back up? How do we expand both of those? How do we drive costs down? And how do we increase revenue? If we can do those two items, our profit margin now turns, and that's where we make some money. So first, cutting cost. This is a line item by line item kind of analysis. You can just walk in and say, how do we cut cost? And a lot of people say, well, I don't know. You start, where do we begin? Well, you got to start line item by line item. You got to look at, first of all, eliminating the use of some goods and services. What could we do without? What could we drive out?
You say line item by line item, and you're talking about like a profit and loss statement.
Yes.
And so before you even start, you've got to have your books in order. You got to have your financial statement, your profit and loss in a format that you're able to know what your revenues are reliably. You've got to know what's recorded in accounting fees is really accounting fees. You need to have your financial statement set up in a way where you can use that as a tool to manage your expenses and look at trends from year to year. And so if that's not the case, you've got to have that set up first to use as a map, as a tool to look at your expenses year to year and figure out which expenses are going up, what's going down, why is it going up. That's what it's important to have your financial statements in order before you begin this process.
Absolutely. So if we look at the items that, and that's perfect mentioning because you don't even know where to start if you don't have it in order, right, to have your books in order. Items can be misclassified or not even in the right category. But what are some things that we can do without? And some of these are hokey and some of these are practical, but cleaning the office 2 or 3 days per week as opposed to 5 days per week, or cutting it back on the frequency, redesigning the Christmas party. Christmas party is one of those items that for years, we're just going to have a Christmas party every single year, and we're going to go spend $10,000, $15,000, $20,000 on a nice blowout party. You'd be surprised at how little morale that may do for your current staff. They may be just as happy to think, well, times are tough these days. Let's have a small Christmas party at a smaller venue, even at your own house as a physician, a catered party instead of out at a venue, and that can save us quite a bit of money.
Yeah, have the party at your house and give out some gift cards that would have been spent on, just paying for food and, the other costs of the parties like Maddox said, can create better employee morale, can save you money.
Yeah, hard cold cash doesn't hurt anybody.
Right.
So handing out a $100 bill to staff as opposed to spending $200 or $300 a head may be just as effective and save us quite a bit of money when we multiply that by the number of heads. You know, sending statements to the old small AR is another item. If you're sending out statements, they cost you with postage. What is it? What's the stamp these days? 47.
I don't even know.
If you got a forever stamp, it may be cheaper, but I think it's 44, 47 cents. If you're sending that out for a couple dollars, whether it be a lab charge, and you send that out 2 or 3 times, you know, you're $1.50 in on spending it for something you may never get. So that's one of those processes that, hey, we don't need to do that. We need to set a cap or a limit or a floor at what level do we stop sending statements at? Is it $3, $4, $5, $6, $7 where we don't just send out an automated statement? Our favorite one, and this we've had many stories with Yellow Pages ads, and a lot of people are done with this, but a lot of people aren't, depending on what market it and where you're listening from. Spending lots and lots of money on Yellow Pages. If your patient population, let me just give a kind of an example. If they're under 40, let's say, probably not using Yellow Pages anymore to go search for their physician practices. Now, if you're a cardiologist, now granted that's a referral network, so you're wasting money there too, or a neurosurgeon, you're wasting money on Yellow Pages. But if your patient base is lower, they may not even know what a Yellow Pages ad is. An OBGYN, they're not looking to Yellow Pages to find out who their OBGYN is. They're using Facebook or their friends or texting. They're definitely not using Yellow Pages.
Yeah, I can guarantee you I'm not going to pick my neurosurgeon from Yellow Pages.
If you do, we're in trouble. You know, the part of that is, that sometimes Yellow Pages do work. If you're in a rural market, and then let's give you an example, maybe a dentist in a rural market where Yellow Pages are still being used, it may be effective. But what we would tell you to do is analyze that cost on investment, you know, ROI, return on investment. Figure out either through surveys or analysis, how many patients are we getting from the Yellow Pages, and weigh that against the cost that we're actually spending. A lot of times these are negotiable items, and we're going to talk about negotiations later on, but the Yellow Pages people understand that their market is dwindling, and they will negotiate the price for you if you just ask. It's part of it. Another item, you know, what can we do without, you know, new uniforms every 12 months versus not, you know, every 9 months versus 12 months. You know, just because we've done it in the past doesn't necessarily mean that we need to do it now. We may not even need new uniforms, and that can run quite a large sum of money for some of our practices.
Yeah. And when staff quit or have to be terminated for some reason, don't fill that spot for, you know, 30 days. And see how your staff respond. There may be inefficiencies there. You may have already been overstaffed in the first place. Wait and see if your staff pick up the slack and can get that job done without having to fill that spot. That'll be, you know, just additional money in your pocket if you're able to save those dollars.
That's a great point, and we've given that point to many practices that just don't hire back. I mean, let's just see what happens, see if the staff can handle it. See if they all have 2 hours or 3 hours a day that they're twiddling thumbs or checking Facebook or, you know, just hanging out. If we've got 10 or 15 people doing that, well, that's a full FTE. That could easily save you a full salary by not hiring it back. We mentioned that every item is a candidate. Where do we start from? And I would tell you on your P&L, start at the top and just address line item by line item. We will say that, unfortunately, sometimes accounting is first, and that's us. So we'll go ahead and put ourselves out there that you need to be looking even at your accounting bill. Are they giving you the value in the services you're paying for? Or are they just doing the bare minimum jobs and giving you a large bill? That's true for every single line item on that P&L. At some point, at some item, let's talk about in the B category, bank charges. Well, some people think, well, those are fixed. I can't stop those bank charges. I would disagree. They're negotiated. You can negotiate not only your bank charges, but your merchant fees that are probably oftentimes hidden in your bank charges because a lot of people process through the bank.
And that's going to be a big item this year and going forward, especially with the higher deductibles. You know, where the patient may have been paying low deductibles of $1,000. If they're on the high deductible plan, that's, you know, like we said, $6,000 next year, $6,600 that they're going to be paying potentially on a credit card. So the credit card merchant fees could double, triple, quadruple what you're used to having each year. So the money saved there could be a big deal.
Yeah, our recommendation here would be to ask your current vendor to give you your listing of credit cards, because there's all type of different credit cards on them, the Discover Gold, American Express Gold, and they all have a different fee. You can take that listing to 2 or 3 different competitors and say, what would my fee be for this month if I was using you?
It's really simple. We do it for clients all the time. We'll get their credit card bill, we'll send it, to some of our contacts at, banks and say, hey, can you run a comparison, see how y'all could do compared to what they're paying now. And pretty frequently we'll find some money for them.
Yeah, we had a large client. I remember the story a couple of years ago. We told somebody to do this, and I think they saved over $1,000 a month just by making one simple call. And they actually stayed with their current vendor. They just used it as leverage power.
Yep.
So, looking even at bank charges, looking at too much space and equipment. If you've cut down on, you should be cutting down on your paper charges. You move to EMR, that additional space that you used to rent or lease, it may be time to go down. If you had a file room that was as big as this room, it may be time to cut it back and stop paying that high retail space. Even if you are keeping paper charts, and you could store them, as high as some medical office space per square foot is, as high as $20, $25, $30 a square foot in some of our newer hospitals. You can save quite a bit of money just by putting some of your paper charts on off-site storage.
Yeah, if you can't turn that area into something profitable or some other use for your practice, and it's a substantial amount of room in your practice, start looking for another spot. Or, if your lease is coming up within the next year or two, be sure to go ahead and start the negotiation process then, and don't wait until 6 months before you have to find a new place. You're going to be in a hard spot and not going to be able to find another location in that short amount of time. So,
yeah, that's good. That's right. And looking at maintenance agreements, oftentimes maintenance agreements are upheld just because there's one of those items that we continue to pay. But if you have a piece of equipment that's running very old and you're still paying a maintenance agreement on that piece of equipment, it's time to drop that. It's not worthwhile. You could replace it a lot cheaper than you could by just upholding that maintenance agreement.
in one instance, this is related to disability and life insurance. Depending on where you are in your career, you may not need that coverage anymore. I had a client last week. We met with him. He's at a stage in his career now where he's close to retirement. He no longer needs his life insurance policies. He no longer needs the disability policies that he's paying. It's going to save him $850 a month, and he's going to cash in those life insurance policies and get the cash from that transaction. So depending on where you are, what your needs are, that could be another area to save, is cutting back on insurance policies you don't need.
Yeah, and hopefully your insurance agent is reviewing those with you, but the insurance agent does have a vested interest in keeping that policy open and premiums paying. That's how they're paid. So disability is huge. Look, if you're 61, 62, 63 years old and your policy only pays out to 65, well, that's only 2 years of payment, 2 years of risk that you're taking that you may become disabled. At that point, your premiums should be relatively high. So you need to weigh the cost versus benefit.
And if it's a personal disability policy, that's probably not going to show up on your practice profit and loss as an expense.
It shouldn't.
Generally, it won't. So if that's something you have, just remember to look at your own, figure out what you're paying individually, and don't rely on your financial statements to show you that cost.
Yeah, we'll go down that rabbit trail for a minute. If your disability is being paid through the practice, the premiums are being paid through the practice, if you are disabled, all the benefits that you receive, the payments that you receive are going to become taxable, which is why we say it shouldn't be outside of the practice. It should technically be paid personally by you altogether. It shouldn't even show up anywhere on the practice. The other part here is using MGMA data for comparison purposes, looking at what does your specialty look like, what are they spending on medical supplies as a factor of revenue, what are your salaries running as a factor of revenue, basically benchmarking the data to make sure you're falling within the reasonable and tolerable ranges for your specialty, or even just to practice in your region. You can get pretty good information from MGMA.
And that's another reason why it's important to have your financial statements formatted correctly, like in the format that we would use. And I think we're going to cover that in a future meeting. But we have a certain format we use so that we can take the overhead percentages, the staffing cost percentages as a percentage of revenue. We can look at that for each practice and compare that to benchmarks. And if your financial statements aren't formatted correctly, your ratios aren't going to show you much, because it's not going to be apples to apples comparison.
And while we're there, we'll put a shameless plug for MGMA. We're in Alabama, and we're raving fans of our state MGMA and our local MGMAs. We think you should send your administrator to those MGMA. They should be heavily involved inside of MGMAs with the burdens that are going on, the administrative hassles, and all the regulations that are in our current environment. I just don't think it's possible that an administrator can keep up with what's going on unless they have their peers to connect with, talk to, advisors, consultants, which we speak a lot of these conferences, to make sure they know what's on the brink and what should they be looking out for to keep you protected as a physician.
Yeah, and what we're able to do a lot of times with our clients is we have a number of specialties. We can aggregate the data. They don't know what clients make up that number, but we can show a client in this specialty, your staffing costs are X% of your revenues. On average, our other clients in the same specialty are this percentage, and we're able to use that as a tool to show them where they're higher or lower than their peers, of our client base in the area.
Absolutely. So once we've eliminated the services that we don't need anymore, or thought about that, our next is shopping for a different brand or provider. So we know we need them, so we've got to have these items. Let's just take medical supplies for an example. Now we can look at a different brand or provider that could potentially offer us lower pricing, because we can't drive them out. And we talk about avoiding the "we've always been there" mentality, which I think is number one on your slide. Looking at, just because we've bought there for the last 15, 20 years doesn't necessarily mean that we're getting the best pricing structure from that vendor. I kind of pride myself in being able to negotiate my own utility bills and cable bill, not my utilities, my cable bill or other outside services, because I think they have incentives that they can bring your cost down, because they offer new customers these incentives. This is the same thing for a practice, and it doesn't necessarily be you as the physician. You need to incentivize somebody on your staff, whether it's the administrator or some other, just the staff all in general, to say, look, if you can save me money, I'm willing to compensate you for that. Because they probably have a way to be able to drive that cost down. They should be little minions, if you will, out looking for ways to save you every single dollar. They should, because it'll ultimately fall back into their pocket.
And the new ACA, the exchange products offer a new opportunity to explore your health insurance options, where you may have traditionally had coverage through your practice for your employees. The exchange offers you the chance to send those employees to the exchange. That needs to be a decision that's considered carefully, because it may not be the best option for your employees or for your practice, but that is an option now that wasn't there before.
Yeah, I think we should dig a little bit deeper on that subject and spend just a minute talking about what's happening in the marketplace related to group plans. And we'll talk about our state for a second. A lot of renewal plans in the state of Alabama are going to happen July 1. Which means a lot of practices now are receiving renewal notices effective July 1, but getting them now May 15th and May 30th on what their current premium pricing is going to be. Historically, medical practice physicians have paid large sums and large percentages toward their employees' health insurance, because they understand the importance and the benefit of having great insurance. So, for example, many of our practices have paid 100% of single, and may pay even as much as 50% of a family plan, which in the long run, that's become an increasing cost. We've seen double-digit increases on premiums, period, and we've absorbed those for quite a bit because we had no other way to fight down those premiums. Well, now there is a different way, and yeah, it does take kind of getting outside of the traditional paying for your employees' premium and getting them off of your group plan. But let me give you an example that if you have someone who makes about 250% of poverty level, federal poverty level, and if you have somebody who's making $10 to $12 an hour, that's probably falling within that range, then they could be potentially, and they have a kid, let's say, they could be potentially eligible to receive a large subsidy from the federal government under the exchange plan. They receive two types of subsidies. One, a subsidy to pay for their premium. And that's based on a sliding scale depending on what percentage they fall within federal poverty level. The second is a cost-sharing subsidy, which means not only do they get a subsidy toward their premium, they get a subsidy toward the deductible that's inside of their plan. they can't receive that subsidy if they're receiving affordable care from their employer. And affordable care is defined, and I know we got a lot of numbers here, but affordable care is defined that their share of the premiums don't exceed 9.5% of their annual household income. Well, if you're providing 100% of single coverage, they can't get a subsidy. And therefore, you become the subsidization for their plan. But if you decide to say, I'm going to just drop everybody, I'm finished and I'm done, you may hurt a few employees that make large amounts of money because they wouldn't be subsidy eligible. But for your people who are subsidy eligible, they could go out and the federal government would subsidize their plan, maybe not 100% of what you've been doing, but very close to, depending on where they fall within the federal poverty level. So it's a consideration that a lot of people are going to have to make in the near future. And as we become more comfortable with getting our people off of our group plans, I think we'll see a dynamic shift to pushing people to the exchange. Whether that's good or not for you as a provider, can't answer that now. We may have a one-payer method, and it may be the federal government, but a lot of people are already pushing their employees toward the exchange products.
This week I looked at two practices. One was a unique situation where their new policy renewal premium was actually lower than what they had the year before, which I think that's the first client I've seen that's happened with. The other, their premiums were going to increase from $19,000 a month last year. This year it's going to increase to $24,000. So a $5,000 increase per month for the same coverage for that one practice. That's a lot for that practice. I mean, that's $60,000 a year increase just this year. That's when it really becomes important to decide if you want to go down a metal from gold to silver and figure out how that affects your employees. And we're right now we're working with our clients trying to figure that out and help them make decisions on keeping their plan, sending employees to the exchange, and figuring out how that impacts their practice and their employees.
Yeah. So we kind of went off on a little tangent there, but thought it was important to talk about that.
That's a huge cost item on your income statement.
Yep. The other part of avoiding the "we've always bought their" mentality is using your friends, your golf buddies, your fishing friend, your church friends, that we've just bought there just to help them. Now is not the time to help stuff their pockets, overly generous with the environment that we're currently in. We've mentioned competitive bids, and we think you should look at your top 20%, figure out the top 20% medical and office items, and get competitive bids on those items. Merchant fees we talked about, even some shipping costs. Some people will absorb those costs. Looking at the equipment of what you're actually getting. When they're selling that, they have a nice margin inside of the equipment. Our maintenance contracts we talked about. Our office supplies, there's so many places now to order office supplies. I mean, I could think of 2 or 3 in our local market. You put those against each other and you could save a few dollars there. That's going to be something your staff needs to investigate and even have them do an analysis for you. What are we spending on office supplies and what does that encompass?
And your drug supplies, when you start looking at medical supplies and drugs especially, be very careful about going with the low-cost provider for drugs. There was a case recently in Tennessee where 2 orthopedic groups were convicted of filing false claims because they purchased drugs online, which ended up being international purchases. And the J code they used to file those claims, the J code is specific to the drug that is used, and the drug on the J codes are FDA approved domestic drugs. If you purchase a drug that comes from overseas, that's not the same drug that's being used, and in turn that results in that claim being a fraudulent claim, a false claim. And so if you're going to buy drugs and buy them cheap, make sure that's not going to happen to you. Just be careful where they come from. Look for foreign language on the packaging. Just make sure what you're buying is what you intended to buy, and don't go cheap and just close your eyes and hope you're right. It can be a big deal. I think the claim with these 2 practices was $1.85 million they had to repay.
Yep,
and the individual that turned them in for it was the sales rep for the drug that they had just recently quit buying.
How ironic is that? Some slight little motivation there. I think the other part to mention there, when you're purchasing drugs, if you're a large drug buyer, many banks have what they call either a purchasing card or a rebate card, where if you put it on that card and extend it out, they can give you nice benefits, 4 or 5% refundable. Credit cards have that too, but oftentimes they're going to carry an interest balance for you, whereas the bank's card will not hold an interest balance for you and can extend your payables out to 30, 60, 90 days. That's a plug for our banks right there to go out. I do have one client who puts $10 million a year on their drug costs. Now they have a lot of drug costs, and their rebate is substantial, up in the hundreds of thousands of dollars by putting their money on this card. So they rely on that. The other part for shopping for a different brand or provider is, can we use some of our staff to do some of our things we're paying outsiders to do? As hokey as it may sound, there are some light cleaning duties that they could do to save some money on cleaning. They could do some bookkeeping duties if we have some additional times laid out. The data entry, where they enter the checks for our practice. We can even do some transcription inside if we're paying a transcriptionist from the outside.
Converting those paper charts, sitting in the room,
Yep.
If you need to use that office space, get someone to start converting those paper charts that you're currently on your staff so you can free up that space in your office.
Yeah, conversion from a paper chart to an EMR, we all know, takes many, many hours of data entry and getting the correct data in. So if they're just sitting around, if they should be leaning, they should be cleaning. That was the old philosophy I should have. They should be leaning. I guess they should be entering information in the charts here. So there's a lot of things they could be doing. Stuffing envelopes for our billing service if that's could save us some additional dollars. But we need to be getting all of our efficiencies out of our staff, and that'll help us squeeze a little bit more out of this cost cutting in order to drive our profit up. So once we have eliminated what we don't need, and then we've shopped for a different brand or provider, we're going to continue to negotiate for a lower price. And we've talked about most of these items here. Delegating to someone who actually takes ownership of actually buying or the costs that are running through the practice. Oftentimes the administrator has enough responsibility already overseeing the financial burdens, the administrative burdens, keeping up with the latest and greatest. And it may need to be someone below them, depending on how big your staff is, and say, hey, you're just my cost cutter. Go and figure out what it is. Come back with me with reports on what I can save money on, where can I cut some cost.
And give them a stake in it. You could give them an incentive for every dollar they save. They could get 10% or 5% or whatever works for your practice, but give them some ownership in that cost-saving job that you send them out to do.
Yeah, and the other part here is get some outside consultants to assist you. That could be a Yellow Pages consultant. That could be your CPA like us, where we do an analysis for you on what you could save. That could be retirement plan administration. How much are we spending there? That could be your wealth management, where you're actually investing your monies. What kind of basis points are you spending there? But looking at all those items will continue to drive our profitability. And then ask your vendors, how can I reduce my costs? That's what can they do to help you? They have a vested interest inside of your practice, and say, hey, look, I need to drive some cost out. How can you help me? Finding some ways to subsidize the cost. I just mentioned the vendors here, the interested parties. All of these people have a vested interest in your practice because they're all paid based on the successfulness of your practice. So drug and supply companies, if we're not in business, we'll lose our business. Equipment manufacturers, Say mentioned earlier, the landlord, occupying that space and continuing to lease the space drives a cash flow for them as well. So asking them, how can you help? What can you do for me? Say mentioned when you're ready to move, when you're ready to negotiate your new space, oftentimes you can get a lot of tenant improvements.
And just taking a step further, one unique way to save money on office space and rent is look for ways to share space with another practice. It could be someone that's a referral source or someone you refer to. That's a unique opportunity. It won't work all the time, but it's something to explore and to think about, because that can mean a lot of savings in rent.
And then the biggest cost, the biggest cost on your line item most likely is your personnel, and how can we continue to drive that cost down? We mentioned using salary surveys or MGMA salaries to determine, what their salaries should be. We had a client recently who asked us to benchmark their salaries for their respective position and tell us where it falls in the percentile. Every one of their employees fell into like the 80 to 85 percentile. And I just mentioned to them, I said, it's probably, you probably have some great staff, but my guess is that not every single one of them are in the 85 percentile quartile, third quartile type performers. So we need to look at how do we drive that back? How do we show them that we can save some costs in that relevant position?
And don't just assume that your staff are underpaid if you haven't given them a raise, in the last 2 years or 3 years or whatever it may be. We looked at a practice last week that hadn't given their staff a raise in 3 years. So we came in, they wanted to make sure they were paying their staff fairly. We did a review of their staffing costs, and as it turned out, they were overpaying most of their staff except for the front desk people, and they were severely underpaying their front desk people. And consequently, they were having an issue with the front desk and collections. And, we determined it's probably because you're not paying enough to get good people at the front, which was very important. So we suggested they look at keeping the people that are doing a good job at the front, maybe increase their pay a little bit, get it into the reasonable ranges with the benchmark data we had, and then don't increase the other people that you're currently overpaying, or they were in the 75th percentile for MGMA averages. So it's important to look at all your staff and not just assume people are overpaid or underpaid. You got to look at each level and figure out what's going on there.
Yeah, if you haven't looked at surveys of your staff ranges in quite some time, I would encourage you to go ahead and do that now. What is a LPN making? What is my RN making? You should know that data and know where they fall into that range. Because the same danger, if they're underpaid, they're probably job searching on you right now, and they may be one of your best performers. If they're overpaid, they better be one of our best performers. And if they're not, we need to keep that salary stagnant for a while, that hourly rate stagnant, or we need to drive it down and determine if we really need it at that higher rate. We could rehire it and save some additional monies on that staff. One of the biggest items that we see is overtime. Staff have a ability to know when they're in overtime and oftentimes manipulate the overtime fee. And let me give you an example. You look at someone's schedule and they have 6 or 7 hours of overtime. How do you have 6 or 7 hours of overtime? Well, they get there at 7:30 in the morning, and they spend about the first 30 minutes checking their phone, hanging out, but they've already clocked in. And then for lunch, they don't really clock out, but they may have eaten in the lunch, in the break room, and stayed around, stayed on the clock, said I worked through lunch, and then they don't get picked up till about 5:30. Well, that's a 10-hour day. 5 hours on the front end, 5 hours on the back. And by the end of the week, if we've got a clinic open 5 days a week, now we have 10 hours of overtime inside of that practice. Now, 10 hours of overtime is equivalent to 15 hours of pay. So 15 hours of pay on a normal 40-hour work week, I'm going to try to do that quick math, it's about 37% increase. Did I do that right?
Sounds good to me.
Okay, sounds good to say. 37% increase just by staying around, by clocking in earlier, staying through lunch, and then working later. Not only is it a 37% increase on an overall hourly rate, it also carries all the FICA cost and the retirement plan costs with that. So that you can go ahead and increase that up by another 10 to 15%. FICA is going to carry up 7.65%, and depending on your retirement plan, it may carry a 3 to 8% cost on those additional hours. So I would encourage you, there are ways to eliminate overtime. One is the simplest way: pull me an overtime report. Show me in the last 6 months who's worked overtime. And the second way to eliminate it would be just say nobody can work overtime without permission. That may or may not suffice. And then there's some other ways that we can eliminate overtime as well.
Staggering schedules is one way. Have that employee that's wasting time in the morning, have them come in a little bit later if they're not doing anything useful in that early part of the morning. Let somebody, like staggering schedules, let somebody get there late. Both of those methods work. Give somebody an afternoon off, especially if they're one of the higher utilizers of overtime. Give them the Friday afternoon or Thursday afternoon off, That'll cut back on overtime. And, using more part-time staff could also help cut back on overtime for other employees.
Right, we can get more utilization out of, instead of paying that additional 37 to 45% overtime pay, we could hire another half FTE for the same amount of money that we just paid someone to work overtime. And it's usually not their best hours if they truly have been there for a 10-hour day. The other part is looking at your surgery days. Do we have staff that are working? If they're pulling charts for the next day, getting you prepared, great. But do we really need 2 people there to pull your charts and staff when you're in surgery and you're not working in your clinic? So that's often a problem there. The last part on the staff cost is summarizing their total package. A lot of people get hung up in their hourly rate. What am I making per hour? What am I making per hour? And they'll go shop you, and they'll find a new job on you for 25 cents an hour just because they need that additional 25 cents an hour. What they don't often understand is what kind of benefits they're getting through your practice. We recommend that you should have a total benefits type of chart where it shows them exactly what you're paying for them. That includes all their fringe benefits. We talked about what are you paying for their health insurance. So they may go jump ship for 25 cents an hour at a new practice, and that new practice is paying 50% of their individual health insurance where you were paying 75%. Well, they don't think about those type of things. They just jump ship for the hourly rate. So a pie chart or a listing of saying, hey, here's your wage, here's your salary, you made $35,000, and here's your retirement plan benefit that I put in your retirement plan for you this year. Here's another $800, and then here's your health insurance that I paid on your behalf. Here's another $3,000. So at the end of the day, most of their benefit, they may only make 70 to 80% of their benefit inside of their comp, and then they have another 20 to 30% sitting on outside fringe benefits that they've never considered.
And the retirement plan benefit is something they'll never know unless you tell them and show them on a sheet of paper. Because the health insurance, they know they have it because they use it, and they may know what their premiums are, they may not. The retirement plan, there's no way they're going to know unless you say, this is the amount I put in your retirement plan through our profit sharing plan on your behalf. You didn't have to put anything, this was our cost that we put in for you. They're never going to know that unless you show them.
Yeah, they won't, unless they're one of those people that are watching their retirement plan like a hawk, and they just end up not doing that. If they have the ability to sign in and log in. One of the best things that I've seen put into implementation is where you convert your sick and vacation pay all to just personal days. So if you used to give 2 weeks of sick and vacation, or let's say 3 weeks of sick and vacation combined, or sick pay through 2 weeks sick pay and 2 weeks vacation pay for a total of 4 weeks, off totally, what used to happen, if you could currently be happening, is whenever they're ready to take a vacation day, they just call in sick, which really causes a problem for most clinics because it leaves us unprepared. They have to call in at 7 a.m. that morning. They knew they were going to be off 3 days ago because they were ready to take this vacation day, and they know they have a sick day. Our recommendation is to not have any sick pay and have it all in personal days. And that way they have to schedule it out for you. And they have to take a personal day when they're sick too, but they'll really be sick that time. They won't be faking it in order to take a vacation. So that conversion can save you some burdens of being understaffed for the day, your clinic not running as well, and it also keeps people from abusing the policy. We mentioned reviewing part-time staff situation and looking at not giving full benefits, fringe benefits to full-time staff. This will be even more relevant if you have more than 50 full-time employees, because you will be subject to the mandate at some point, the employer health insurance mandate. You will have to offer insurance to anybody who's full-time. So it may be a benefit to have some part-time people. We already mentioned the benefit of having part-time people that help you whenever you're looking at overtime, who can help you float out your schedules and not pay so much in overtime. But making sure you review that part-time situation and make sure it's working for you. A lot of times we find out that part-time people, this may be a stereotype, don't give the same type of effort that you would in a full-time person. So that's the danger of employing part-time people. All right, so we've talked through quite a bit of time on cutting cost, and as part of our curtain talk, cutting cost was one item, and then increasing revenue is the other side. So we're going to move into, well, I've cut all the cost out I can. How can I actually increase my revenue? And there's no crystal ball here. I wouldn't say these are some tips and tricks to help you potentially increase your revenue. I would tell you, let's see if we're on the right slide. We are. First, lengthen your work week. The power of one more clinic and one more day is very effective. We'll go to a clinic, we'll do a consulting analysis for a clinic, and we'll ask the physician, are you working as hard as you can work? And he'll say, of course I'm working as hard as I can work. I can't work any harder than I'm working right now. And so the next step we go to his staff and his nurses, and we say, is Dr. Smith working as hard as you possibly think he can work? And they kind of smile and smirk at us, and they say, well, are you going to tell him I gave you this answer? And we said, well, no, of course not. I said, well, he doesn't get into the clinic every day until about 9:15. And he doesn't want us to book his first patient until about 9:30. Well, that's a problem. Increasing the hours in the workday can only increase the revenue. Most likely your cost that we just talked about is not going to change. It's a sunk cost. Your staff, you're going to pay them if you get there at 9:15, unless you're asking them to be there late, you're going to pay them when they start there at 8 o'clock that day. And so they're going to sit around and you're not going to be creating any more revenue, but you will have the cost associated with it. And let's just say it's one more patient. If it's one more established visit or one more new visit, let's say it pays $50 to $60 for that visit. Well, $50 to $60, 50, let's make it easy math over here, times 4 days a week. If you're only open 4 days, it's $200 a week. And if we do that times the number of years you work, you could be at $10,000 in a bottom line. That could be your bonus for the year with this current environment. But just by increasing your clinic by one more day could increase your bottom line by $10,000. That's just an easy example.
And that ties into what we mentioned earlier with taking a space in your office, a records room or whatever it might be, adding another patient room. Adding that one patient room, utilizing that space a little bit more can mean a lot to the bottom line.
Okay. The other part here is taking fewer vacations. Now, remember my caveat at the beginning, which is don't sacrifice everything for the bottom line. Vacations are important. It's important to be with your family, but taking them at the right time is also important. So, taking them over Christmas when everybody wants to come and see you when kids are out of school, if you're a pediatrician, or if you're, taking them at the peak time of your period. If it's your peak time, it may be everybody's peak time to come see the physician as well. Sometimes they go hand in hand. So you got to line it up depending on your specialty, depending on what you do, depending on what your patient flow is, and you should be able to capture that historical data. Make sure you don't take off the busiest week of the year. Don't take off in the middle of the flu season if you can help from it. Also understanding that a vacation is very costly because unless you're forcing your staff to be off during vacation, which most people don't, you have two things going on. One, your costs are staying the same, and two, you're not increasing revenue. So if let's just say you decide to take a 2-week vacation to Europe. Well, let's say your overhead's 50%. So you take 2 weeks out of the month, to take a vacation. The other 2 weeks are going to be used in the month to cover your overhead. So you didn't make any money that month. Not only on top of that, you also probably spent a lot of money in Europe for 2 weeks. So the cost of taking that vacation is 2 weeks worth of revenue, and then whatever you decided to spend in Europe during that time period. So it can be costly. One of our colleagues, Jim Stroud, tells a pretty good story of the cost of one of his physicians who said, my vacations cost the most because when we go to, I can't remember exactly the story, but when we go to Vail, my wife's got to have the fur coat. And when we go to Napa Valley, we have to drink $300 bottles of wine. So we understand that those vacations can be quite costly as well, depending on who you take and where you go. But remember my caveat at the beginning, don't sacrifice it all for the bottom line.
Yeah, we're not suggesting you don't take a week off next year. We're just saying...
we might be.
We're just saying if you're already taking 10 weeks off, we're just making you aware of the total cost of those vacations.
Yeah. The other part about increasing revenue, item number 3, is are you ready for a new associate? And we talked a little bit last time about succession planning, and we'll have some more clips on that. But at some point, you may be giving up revenue if your patients are leaving and going somewhere else. If I called your office right now, when is your next available time slot? If it's tomorrow at 3 o'clock, you're probably not ready for a new associate. But if it's 4 or 5 weeks from now, you're probably ready for someone to have some help. And that's an easy way to figure out how booked are we for the schedule.
Yeah, you got to bring an associate when the time's right because you don't want them to cannibalize your own production, which is going to happen to some degree. But bringing someone in when you're already not busy, and your revenues are going to go down. It's got to be at the right time.
Yeah. And then finding the right person. We could spend a whole seminar talking about succession planning and the importance of finding the right person, but basically they need to meet 3 criteria for you: clinical, behavioral, and work ethic. And what we mean by clinical is, do they have the hands for it? Can they do the clinical type work that you're doing? And can they do it well, and will your patients like that? Because you will be transitioning some of your current patient base to this new associate. The other one is behavioral. Do they treat your patients, do they treat your staff in the same way that you treat them? Or do you have someone who curses around your staff and around your patients and treats them in a manner that you would never do such? That's not going to work out. And then lastly, work ethic. If you work, are they willing to work with you, work the same amount of hours that you're working? If they want to work 30 hours per week and you're accustomed to working 60, it's probably just going to frustrate you to no end. So, knowing if you're ready for a new associate can be a way that we can capture and increase revenue. It also, we talked last time about the way you can make a profit margin off a new associate. Whereas you bring them in and they're not in ownership, if you can let them see some of your patients and your patients are happy with their performance and their clinical abilities, we can pay them a modest salary and then make a profit margin on the production that they actually have. And that's work that gives you work-life balance. You can go take your 2-week vacation to Europe now because you have someone to be able to see your patients and continue to increase revenue. Now, you do have to pay them that salary, but there is a profit margin built into them if you've structured the salary correctly for them as well.
Yeah.
And then our 4th point here is to improve the tempo. How do we improve the tempo? Well, we like to say just start fast. If you've ever read that book, Eat That Frog, it says go ahead and eat that frog, that big problem first. So just jump on your patients and get going. If it's the problem patient, if it's a problem patient, go ahead and just knock them out. Get them going. That's when you're at your best in the morning.
You want to set the tempo early. Get your patients moving in quick. You don't want to be like a slow engine starting where you don't hit your stride until after lunchtime. You want to set the tempo from the first patient you see and keep that tempo for the rest of the day.
The other part is get you a fast nurse, or if you have 2 people, put the fast nurse with the slow physician. That nurse will get them going. They'll have charts pulled. Eventually they'll get them to hurry up and get the clinic going. Improving the tempo is a big item. And then lastly, pack the schedule. When you packing the schedule, let me give you a plane analysis. We all know that a plane overbooks by, I think it's 20% or 25%, and that's why if anybody would like to go tomorrow, we'll be willing to offer you a $300 voucher. Well, the same thing goes for your practice. Do you know your no-show rate? If you don't know your no-show rate, you should, because we should be booking in those slots. So if your no-show rate is 15%, well, we should be booking at 115%, because we know we're going to back out 15% of our patients, and then we have a full packed schedule. And you can do it gradually. This isn't something you have to do tomorrow. If it's your no-show is 15%, you don't have to book up 15%. Just tweak it up line by lines to eventually we have a full packed out schedule. The other part of this no-show is, are you encouraging no-shows? And do you know what your specialty no-show is? For some reason, we've heard the story, urologist, when men decide they're going to have a vasectomy, the no-show rate is 60%. We have no idea why that's the case. We think their wives book those appointments for them, and so when they have a tendency to no-show. And urologists have figured that out, that we need to pack our schedules.
$100 vasectomy, I'll give up my $100 and go to the baseball game.
That's right. So, and if you've booked a surgery for the day, well, then you've really booked a large producing spot for you, for your practice. So you've prepped them, got the nurse ready, such as a vasectomy. We've got either the outpatient center ready to go, or if you're doing surgery inside the hospital, we've time slotted that for them. And we've got to make sure that we know that, 1, they're not going to no-show onto us, and 2, if we've booked it out enough in case we do have a no-show. Second part of that is, charging a no-show fee. This has been a hot topic for many, many years. You can't charge a no-show fee for your government payers, but you can try to implement a no-show policy or a fee for your chronic no-showers. And I would just tell you, if you've had somebody who no-shows you, more than once or twice, they're probably not a patient you want. And two, you could charge them a potential fee, once you've given them 1 or 2 grace periods to say, hey, look, it's a $50 reinstatement fee, no-show fee. Be careful with that, because it could drive your client base away if you're not careful with how you present that policy.
But it's good to give them a call and say, and don't give them excuses for why they missed the appointment, but say, why did you miss your appointment? And let them give their reason. And they may realize how rude or ridiculous it was for them to miss that appointment. And it's also good, instead of calling the day before for a reminder, call them 2 or 3 days out, give them a little bit more time, so they know their appointment's coming up.
Yep. So after we've looked at, adding additional time to improve efficiencies, we want to look at productivity. And part of that is capturing all your charges. We know there are 2 ways when you capture your charges. One is undercoding or overcoding, and both of those have huge problems. If you're undercoding, you're leaving money on the table, time and time again. You could lose $10, $15 between a visit 3 code and a visit 4, and when we extrapolate that into large numbers, it's a large amount of money just by you've done the work, you just miscoded. You could also be overcoding. The problem with that is when you overcode, we know that RAC audits, Medicare audits, even Blue Cross, even some of your commercial payers are looking at overcoding. CMS a couple of years ago were looking highly into 99215s to determine if you had the proper documentation to actually bill level 5 code. And so overcoding, undercoding can be a problem, but we need to make sure that we're at least capturing them all. I would tell you in this part to actually have a chart on it and determine what's your misfire rate. Everybody needs to know what their misfire rate is. How bad am I? We looked at one guy who had coded 10 level 5s, and of the 10 level 5s that he had looked at, not a single one was a level 5 code. He didn't have the proper documentation or the actual prognosis diagnosis to actually validate a level 5 code. So have a chart audit done. I know SMA does that. We do that ourselves. And it's just a minimal charge to determine if you're leaving any money on the table or if you're putting yourself out there for risk.
And it's good to look at that for a practice and compare all the doctors within the practice, because theoretically most of the patients that practice sees should all be about the same as far as how sick they are. Mm-hmm. And if you have one doctor that's routinely upcoding and coding 4s and 5s, and another doctor that's routinely coding 2s and maybe a 3 every now and then, you've got a problem with the consistency among your physicians. So it's good to have that done and compare where your doctors fall within a bell curve for that specialty and within their own practice.
Yep, it's great information. Accounting for charge tickets, I may be a little bit old school here, but just making sure that everybody who comes in, we have accounting for on our charts. We're actually putting our codes in. We're actually billing for those services for the day. So matching up what was actually put in, what was coded per our patient visits. We used to do that through our super bills, and maybe coming through your electronic super bill now on your EMR. Also here, talking about what we call the, can you look at PD2 syndrome, which basically there's 2 problems here. One is, patient comes in, one brother, and oh, by the way, can you look at brother 2? He's got a little scab on his, forehead. Well, we're not getting any charges for that, but we've seen 2 patients. The other one under ACA is that we have a lot of covered services under ACA, which means they're covered with first dollar, no deductible, no copay under the Affordable Care Act. Well, they come in for affordable care service like a MAM, and they had the MAM done, and oh, by the way, can you look at this as well? They're trying to get out without paying the deductible or copay, and we were just leaving money on the table. If we do it, no, we can't look at that. You're going to have to schedule a separate appointment for that service and come back and see us. I'm very sorry, that you're here for this. So those are some examples of making sure you're actually capturing all your charges and some part of your productivity. Reviewing your fee schedule and making sure that, sorry, we already looked at that, didn't we? I don't know, we had 2 there. Reviewing your fee schedule, we'll go ahead and talk about that for a second, making sure if you do have cash payers that your fee schedule is in line with the actual services, that it is appropriate, that it is above your insurance balance amounts, and that if we do have a cash payer, we have the right fee schedule for the actual CPT itself. Looking at checking the mix. What's important with the mix is who is our mix? Who's our payer mix, and what is our trend in the last couple of years? We could potentially have the problem of a lot of people going to Medicaid. Medicaid was expanded in many states. For our state in Alabama, Medicaid was not expanded, but it could have been in your state from the with the Affordable Care Act and the government money that was given. So some of your commercial payers may be under Medicaid, and same thing as our population begins to age, we're going to put more people on Medicare. So those baby boomers are going to go to Medicare. They could be getting off of commercial contracts. Sometimes you have some ability to, payer trend mix. You may be at OBGYN and say, I'm not going to take Medicaid because I have enough of my commercial payers, and the payment between those two is a large amount. Sometimes you don't, but you got to understand if we do have those cuts in our pay, that could be our biggest productivity. We could be seeing the exact same number of patients for the year as we did last year, but if our payer mix shifted by 10% and the payer mix went from a commercial to a government payer, we may have lost quite a bit of revenue just by our payer mix trending down. So looking at that and making sure that you're in the right payer mix. Second part here is analyzing your procedure mix. What are we doing? What type of procedures are we making money on? We talked earlier about infusions and drugs. You should find out what is my profit margin for that drug. And that's for, let's say, a rheumatologist. What kind of money do I make on each of these drugs so that you can try to control the cost, one, and two, understanding how lucrative or how profitable it is for those infusion drugs.
Yeah. And like for a plastic surgeon, you don't want to fill your schedule up with Botox every day. You want to fill it up as much as you can with facelifts or whatever it is that you do that makes you money. So you want your scheduler to be on par with what makes you money and have that filled up every day as much as possible.
Yeah, and they can't do that without us understanding what we make for each procedure. So then we can give the proper guidelines to say, look, as a plastic surgeon, I want to book a facelift way before I book a Botox injection. Even if my schedule's full, we got to figure out a way to get that surgery in there. For a dentist, if we have any dentists on the line, looking at are you a drill and fill kind of dentist versus a cosmetic? We can sit up and clean teeth all day long and drill and fill some cavities. But if we just saw one implant or one veneer for the day, it's 4 times more lucrative than it would be, or even a crown could be 6 times more lucrative than it would be to have that cavity filled. So we could be busy, we could have the right payer mix, but if we're not doing the right procedures, then our productivity could go down. Looking lastly at our referring. Who's not referring to you and why? If you're a big referral, if you're a cataract surgeon, and your optometrists are driving your referrals, you need to understand where those are coming from and why do they keep referring to you, or why are they not referring to you. That could be happening from, asking your patients where they came from. You can do a referring physician survey and figure out why are they referring to somebody, what's the benefit there. Maybe I need to bring them some chocolate-covered strawberries to help them refer. How do we get them in here to refer for us is important on actually driving our referral mix, our procedure mix, and our payer mix. And then our matching our capacities to our demand. Where are our bottlenecks? What are the days that we're scheduling? What days are busy? What days are our office packed? What days can we book in even harder? Monday, Tuesday, Wednesday might be completely packed, but Thursday, Friday for some reason is completely light. Nobody wants to book those days on Thursday or Friday. This goes hand in hand with, we may have some opportunity to bring an associate in. So if we have a lot of availability or a lot of patients who want to see Friday afternoon appointments, but we're off on Friday afternoon, well, do we know that? And could we stagger our schedule to work differently? Could we bring one of our partners stagger their schedule? Could one of our new associates stagger their schedule in order to capture that revenue? Is just sitting out there waiting for us to harvest. If everybody in the state or in the city you're working in closes on Friday afternoons, there probably is somebody who wants to see somebody on Friday afternoon, and you need to capture that market. And then what limits your practice? Well, what are our limitations on actually, I went to a waiting room of one of my clients recently, and I ended up standing up. And I said, wow, well, no, we may have a problem here because we just need a bigger waiting room. Space was a limitation because nobody wants to, it was actually an OBGYN. Nobody wants to come in, especially as a post-follow-up visit with a newborn baby on a chair and have to actually stand up. So I said, look, you got to do something about this. Is it our call-in time? If I call in trying to speak to you as my client and I wait for 4 minutes in the front end line for somebody to put me through, that's a problem. In this day and age, people don't have the patience. It is a here and now generation, and they want it here and now, and they expect it. And if they don't get it from you, they're going to find it from somewhere else. That could be a limitation. A limitation could be exam rooms. Do we have enough exam rooms to actually see our patient volume? We could talk about all day about bringing new patients in, but if we don't have the exam room space to actually see them, then that's another problem, and that goes into our lease space.
Could be name recognition. Do you need to advertise? Do you need to create some more relationships, referral sources? You just got to figure out what's going on, what's limiting your practice.
And it could be, I have some dentists who say, well, my operatories are completely full all day long. I can't see anybody else. Well, we need to figure out how many more operatories we need to put in order to see those actual patients and get them pushed through. Nights and weekends and use of physician extenders. Do we have patients that want to say that this new generation is all about some nights and weekends? When can you fit into my schedule? Not necessarily when are you open. So we already talked about vacation and planning of your vacation and actually making sure that it falls within the right timing. Taking a weekend vacation is probably better for you than taking a weekday vacation. Never take them during spring break, Thanksgiving, or Christmas. That's when everybody wants to come. And then, of course, we talked about the opportunity cost of actually taking a vacation. So, I have some dentist example for some reason tonight, but if a lot of people at night want to try to call their dentist to make a dental appointment because they can't do it during the day. They may work for a physician who said you can no longer have your phone on you during the day. So they actually have a call service that picks up and books appointments during the night, and they book them for the next week as they come through. So they capture a lot of new patients who want to make appointments and know that they're open at night. Hey, 6:30, 7:30 at night, they pay their staff to actually have someone on call and have that phone and book appointments throughout the night. And it's worked out well for them. That's one of those ways they differentiate themselves inside of the market. Use of physician extenders. Do we need to put a PA in our practice to see people with dermatology? Well, we know that's a rampant use. Come see my PA and see the nurse and see the actual dermatologist if I need to. OBGYNs have been using nurse practitioners for a long time, and even in RN to do those services for our post follow-ups, for our follow-ups, even inside of our global period. They've used nurse practitioners in order to see that visit. Using a physician extender will allow us to produce more revenue. It's just like hiring another associate, but just at a cheaper cost to do some of the duties that we can get paid for. We have incident 2 billing as well, and we're not going to get into that, but the ability to bill some of those services when one of our physician extenders actually see the patient. And then adding new revenue. How do we add new revenue? Can we add some new procedures and new services? For a OBGYN, what's happening in the market currently and what's happened for the last 5 or 6 years is adding weight loss clinics and laser liposuction and laser hair removal. They've become innovative at ways to make new money relevant to something other than delivering babies and seeing appointments. And what are some of the other things you can do? New procedures and new services you can bring in. What are some of the things you can sell? And that may be for a family practitioner that may be bringing your stress testing in-house. And they're actually turnkey operations. They provide you stress testing facilities. They come in, they actually employ the person. You do the stress test in-house. Your cardiologist referral may not like that, but you could do that stress test and capture some of the revenue there.
A gastroenterology group may have opportunity for, like you said, a weight loss. They could bring their lab in-house, which I know could be very profitable. So there's a lot of opportunities. You just got to look for what could I do, what could I bring in-house that I can make money off instead of paying someone else to do it.
Yeah, dermatology's had the ability to bring in new procedures and new services, and they're getting into, they've gotten into everything. even spa services for some dermatologists. They've even gone that far. So that's the ability of bringing in new procedures and new services is another way to add some new revenue. How about satellite offices? Where is a place, where is a market that's currently underserved, and where can we travel to that market, or where can we get someone from our office to travel to that new market?
Yeah, it's important to have the staff there and the other physicians there to be able to go to these satellite locations, because you can't count on yourself being the main producer in that practice and create a new satellite and expect to be able to split time and maintain the profitability that you had with one location. You got to have what we call a road warrior and have someone available to go to those locations and see patients. You can't rely on yourself to be able to do all that.
Yeah, and if you're a young physician in a young practice right now and you're booked out your days and you have lots of gaps in your days, you may slim your practice down to Monday to Thursday in the location you're currently in, and on Friday you may travel to a new location to begin to market over there, because that may be the only way you can completely book out your schedule. And you got to look for those markets that are currently underserved. Hiring other specialists, I don't have that here, but hiring other specialists inside of your practice. An ENT surgeon may hire an audiologist, may hire an ENT generalist. There are other specialists that you can hire inside of your practice in order to capture some of that specialized revenue. But looking at other specialists inside of it will help you generate revenue as well. And then establishing a website. Why don't you tell us about establishing a website? Should we do that or should we not?
Well, for a lot of people, that's the first place they're going to look to figure out who you are, what you do. And I think it's important, especially now, to have a website, if for any other reason, just so people can get comfortable with you before they show up in your office.
Yeah, we are the tech-savvy age right now, and that's the first thing is Google search. Whenever it's time to look it up and see what your practice is all about, see what you look like as a physician. Not that that matters, but some of the younger population wants to know that. The ability to book appointments on your website. If you have that capability, there's all type of things. Your patient portal, if you want to do that on your website, there's all type of things. Getting to tech savvy, depending on your patient population and their age, it's going to be important going forward. If it's not already very important, and Facebook, especially for OBGYN clinics at this point, pushing that out, getting people to like it, Twitter, this is all going to become more and more relevant the farther and farther we move down the road. And then lastly, collecting for what you do. We have an epidemic in America that for the longest time you could go see a physician, not pay copay, not pay any type of deductible, and get billed for it. And people have become accustomed to that procedure process. You are good at what you do. Don't get timid about getting your collections. A lot of people say, I don't want to take my copays up front. It just intimidates my patients. That is becoming the norm now. If you're not getting your copays up front, if you're not getting your deductibles up front, you're probably losing money, or you could be gaining more money. It might be a better way to say it. So making sure you're good at collections. There's a few things here that will help you do that. Who's appealing claims and what are the outcomes? If you have a denied claim, who's working those claims? I recently had a practice, their AR went up about 20%, and it was all because nobody was working the denied claims, the zero balances. What was going on? Why are we not getting paid on this claim? That can leave revenue sitting on the table. That's not getting paid for what you do. Are you collecting most copays and deductibles? We started off this conversation tonight talking about the increase in copays and deductibles. If you don't have that sign at your front door that says, we are collecting copays and deductibles at the time of service, you should have that on your front, on your door. You should be collecting all the copays and deductibles. Is your staff on board with this? Have you taught them to collect that money? Do you have the right personality in that, in that part of where you collect money? And this process starts way before they actually walk in your office. It starts at, when they book the appointment. So, thank you for calling, booking your appointment. Can you go ahead and give me your insurance information? Running that instant eligibility for them, saying, when you show up 3 weeks from now, you understand you have a $30 copay. Please go ahead and prepared to have that with you. Second step, reminder appointment. Reminder appointment. Your appointment's in 2 days from now. Just as a reminder, please have $30 when you show up. That's the second step. Third step, when you show up, hey, good morning, welcome, sign in. Mr. Casey, please come back up. You know, you're aware you have a $30 copay. Please collect it now. And then the last step on the way out the door, if you haven't gotten it on the front end, getting it on the back end. So every step we move closer, every 1, 2, 3, and 4, if you will, every process we go through, our likelihood of actually collecting that money is going down, 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 down. If they go ahead and see the physician, it's like buyer's remorse. You know, they saw the physician, they didn't like their outcome, they didn't like the physician, they didn't like your bedside manner, they didn't like the fact that they really didn't have anything wrong with them and they were there. They're less likely to pay. So if we don't get our copay on the front end, they're going to say, I don't have that money. You know, I don't. Can you bill me for it? Because that's what they're accustomed to, and two, it's what they've done in the past. So we've got to get it on the front end. We've got to have the right person and the right personality collecting that money. We can't have Sweet Betty on the front end asking about their kids and, you know, tell me about your grandkids and what's going on in your life, because they're going to be less likely to say, oh, and by the way, I need $30. We need that hard personality to say, you owe us $30.
Right. It doesn't need to be, you know, are you going to pay today? It's got to be, how are you going to pay today?
Yep.
Like, there's no option, you know, give us cash, credit card, check, you know, whatever it is. But it's got to be someone at the front that can be assertive, but do it with a smile. A lot of the times it's someone that's very likable and can almost just coax the money out of them, and they can be happy about paying it.
Yeah, and this is an art. I mean, this isn't something that is, you know, straightforward. We actually teach a class to practices on how to actually collect money, and that's a whole hour seminar on just how do you collect money and get better at collecting money. You know, looking at your collection procedures, when do we turn people over to our collection process? If they figure out that you're never going to turn them over to collections, word spreads pretty quickly. My example is that I had an OBGYN clinic that would never receive the $500 deductible for receiving a baby. Well, everybody in the city knew that, and everybody wanted to have their baby there because they knew they would save $500, and word spread pretty quickly that they would never turn you over to collections. But we need to look at our procedures of when we turn them over to collections. Is it at 60 days? Is it at 90 days? Do we give them an option at 90 days to make a payment plan? Do we not? You know, and getting that consistent and making sure that we all abide by that and all your staff abide by that is the right way to actually collect for what we're actually doing. You know, looking at professional discounts and courtesy write-offs, we used to give those even to our fellow physicians. We used to give them a, you know, that's fine. We won't collect your copay as a professional discount. But if that physician now has a $2,000 or $3,000 deductible, well, now we're giving away quite a bit of money. So we need to make sure we're looking at those, that we aren't giving courtesy write-offs, you know, to everybody we know, all our friends, our fishing buddies, our pastor, you know, our sales reps. We need to make sure that we're not leaving money sitting on the table.
And, you know, the collection process opens up an opportunity for employees to steal from the practice, because you got someone at the front that's handling cash. You may have that person also doing the books or the bank reconciliation, a lot of things, because in medical practice, a lot of times there's not enough staff to have what's called segregation of duties, and which is your best option to try to prevent fraud. So part of the collections process is also trying to keep what you've earned and what somebody pays you, and minimize the threat of employee embezzlement. You know, as I mentioned, having internal controls is important. When you can't have the proper internal controls, it's good to have the perception that someone else is going to come after them and look at what's being done. So it's good to have the physician involved in the day-to-day process of looking at AR, authorizing write-offs, and also having a CPA or some other advisor that is going to come in and look at the books every month or every quarter, just so the people in the practice understand that there's another set of eyes looking at what's going on.
Yeah, and then lastly, we have a word of caution, and Sade mentioned this earlier, profitability defined. We talked all about profitability, but not understanding and tracking your true profitability is a problem. Sade mentioned formatting your financial statements in a manner that where you bring physician costs below the line and look at our true operating costs. If your physician costs are up above the line, it's almost impossible unless you manually pull them out to determine what your true profitability is. Because we think you should be tracking that profitability. If your profitability is dipping down every single month or every single year, we need to find out why. That needs to be our dashboard or our ticker that says, boom, we need to figure out what can we start to tweak again. If it stays stagnant, that may be okay. But we need to figure out how do we pull back this curtain, how do we make more profitability. Documenting these efforts, what are you doing, what's working, keeping an annual file of things that I should do. So merchant fee is a perfect example. Once a year, twice a year, you should pull these merchant fees and begin and say, hey, I should renegotiate these.
Yeah, put it on your calendar. Every twice a year on this day, and then 6 months from now, I'm going to look at this expense again and see what I can negotiate better.
Yeah, and it may not be you that it's an annual file, but an annual cost-cutting, revenue-increasing file. What are some of these tips you learned today? What are some of the things that we have done in the past that we need to revisit and make sure that it's still working every single year? What are those items we shouldn't be buying? Should we review our financial statement? Those are some of the items that we think will be important as profitability looks at. So as we continue, here's our information again. But as as a finishing conclusion, we did mention that the burden of a medical practice is increasing, that everybody wants to make less money, and that our costs continue to rise. And hopefully some of these tips we gave you today will allow you to open back that curtain back up, cut some costs down, increase some revenue, and get you back to making more money, which is what we as your CPAs as our ultimate goal at the end of the day. So, do you know if you have any questions, say, on your?
I checked earlier and we didn't.
Okay.
Let me check.
So we have lots of experts on the phone, on the line, so that's a good thing. But if you do have questions in the meantime, here's our information. Feel free to email Say or myself, and here's our phone number. Like we said, we're there. We see medical practices all day, so if it's not related to profitability, we'll be happy to answer any question you have related to a medical practice. So we appreciate your time tonight, and I think our next presentation is in about 2 or 3 weeks, but you can go to SMA's website to determine that date. We appreciate our sponsors today and our co-partners, which is Southern Medical Association and Southern Medical Services, Jefferson County Medical Society, and of course Warren Averett. So thank you for your time, and we'll see you next time.
Thank you.